My name is Wells Messersmith. I'm a professor and head of the Division of Oncology at the University of Colorado Cancer Center. I also serve as Chief Medical Officer for Oncology Services for UC Health. And I'll be talking today about targeted therapy for colorectal cancer. And we'll go ahead and get started with a paper that got a lot of attention nationally. And I think many of us received lots of messages from our patients wondering, if this pertained to them. And of course, unfortunately, it's actually fairly rare to have an MSI-high rectal cancer, but we do see these patients. But what an amazing story. This was using a checkpoint inhibitor called dostarlimab, and it was administered every 3 weeks for 6 months in patients with stage 2 or 3 rectal cancer. And what's different about rectal cancer as opposed to other cancer types, of course, is that sometimes patients who are unresectable end up needing to have an ostomy the rest of their lives. So if you're able to handle them in a non-operative management type of way, in a medical way, that can have an incredibly life-changing effect. And of course, many of us have had patients who steadfastly refuse to have an ostomy and basically say, I'd rather die than have an ostomy. Or they have poor anal function and don't have continence and have to wear diapers the rest of their life. So this is, this is actually sort of a major breakthrough. And the bottom line on this, and they're actually over 20 patients now, maybe even close to 30, as I've heard Andrea give different talks at different times, but really had incredible efficacy here. And you can see the treatment portion of the study followed by near complete response and complete response. And basically, everybody responded. I think later on, this one light blue bar, number 12, ended up having a complete response as well. And so it's pretty rare for a 13-patient study to hit national news, but it did because for these patients, again, it's pretty life-saving. And this is from the publication, and on the left, you can see the demographic table. I mean, some of these patients even had T4 disease, and 15 of them had positive lymph nodes. And if you look at baseline, which is the first column of pictures, 3 months and 6 months, you really see these impressive local responses. Endoscopy, you basically can't see the tumor anymore. And as you look at rectal MRI and PET scan, you can see that initially you see this PET positive, fairly large mass in the rectum. And then it basically goes down to nothing. Now, of course, these patients do need to be followed, which they will all be followed closely with sort of a non-operative management protocol. But at this point, you're able to spare these patients surgery and just keep a close eye. And so this is incredibly encouraging. On the left graph, you see biopsy specimens before and after, and you see the viable tumor cell content. Of course, part of this will be sampling in terms of what they're actually able to sample. But again, you can see that the viable tumor over time comes down very nicely. Now, the kinetics are a little different patient to patient, and also would depend on when they're able to carry out the biopsy, but very nice results there in terms of tumor response. And one explanation could be that you're getting increased immune activation at the site of these tumors. And at the top bar graph, you see the before and after, looking at CD8 T cells and also looking at CD20. Both in the epithelial compartment where the tumor is, but also in the stromal compartment. And you can see actually many of the changes are mostly stromal.
I guess one of the things about this is not like what you see in metastatic MSI-high. I mean, plenty of those patients don't even respond, let alone have a complete response. And I know, as you say, it's a big, when I first saw this, I was thinking, a small number of patients, maybe, I don't know, but it just didn't really resonate with what I understood about, this situation. Do you think it could be the fact that it's sort of a primary as opposed to metastatic? I know there have been some attempts to look at other sites, colon, for example. What happens when you give anti-PD-1 to MSI-high localized colon cancer or upper GI cancers? I don't think everybody responds, do they?
No, not everyone responds, and there does seem to be something different about these primary tumors because we just wouldn't expect you to bat 1,000. And whether or not it's because you still have the lymph nodes in place, you haven't had, some kind of big surgery. All of those things could come into play. So I'd say the response here is higher than we expect to see. That being said, even in the advanced disease setting, even though the lesions don't go away completely, you often have patients who've been treated for 2 years with immune therapy. There's still a small lesion there, but we just leave it alone because historically we found if you resected those, you often just found a scar. So exactly what's going on with metastatic patients, I think, is a little harder to say because we don't go in and resect, every little lesion that we saw in the beginning. Because I have patients that I put on immune therapy studies way back when, where they've been off immune therapy now for several years. They still have some lesions present. I still see them every 6 months or so, but those lesions haven't changed, in many, many years. And I think the patients are cured. And I think most of us have had those types of experience in MSI high cancers. And whether it's gastric or biliary or whatever you have, you often see these incredible responses. But I do think there must be something different about the immune milieu, if you will, of a primary tumor, and perhaps the presence of lymph nodes that lends itself to having an even more impressive response.
I guess it could be the rectal location or microbiome. What about MS stable rectal cancer? Have IOs ever been given there alone or with Nivo or with regorafenib, for example?
Yeah, so people are starting to look at that. There's trials that are in various stages of development. The issue with the drug, I've actually seen proposals because, as you know, there is some activity of a checkpoint inhibitor, for instance, and tyrosine kinase inhibitors, right?
Right.
So there's some proposals to look at that in patients who have unresected primary tumors. The problem is the VEGFR activity. We worry about perforation and bleeding when you have a tumor in place, that's invading much of the wall of the gut. So we're going to have to think about that from a safety standpoint. We'll just have to see how this story plays out. But there does seem to be something different about that preoperative setting that lends itself to efficacy of immune therapy, even in MSS tumors as well.
Any reason to think the location could have anything to do with it?
You're right. I mean, it's a different microbiome. It's a different embryonic origin. So I think that's certainly a possibility. Although I would say I have had remarkable responses at the primary tumor site in many different tumor types.
You're saying the Memorial group now has 30 people, and again, they've all responded?
This is sort of verbally said on the podium at presentations, and yeah, they're still batting 1,000.
Wow.
Yeah.
So interesting.
Yeah, but I would say, unfortunately, this is a very rare occurrence. I mean, Colorado, we see close to 1,000 cases of colorectal cancer a year, and we have very few of these. I think it's no mistake that a big place like Memorial is able to get this done. So it's very rare. It again shows that we really have to do reflexive MMR testing. And as I do second opinions, I still occasionally will have cases where they haven't done the MMR testing. And so from a patient perspective, a provider perspective, the key thing is to get that done. Looking at dual blockade, so the Niche 2 study, this was really more of a pilot study in a sense. They gave a dose of IPI and then 2 doses of Nivo, so kind of different from the Memorial experience where they gave the 6 months. And so it was all around safety and feasibility. And I do think that we really haven't had safety signals with regard to surgery after immune therapy, which is great. And I think that lends itself to preoperative approaches as opposed to agents, that have VEGF activity or things where you might have to worry about perforation, bleeding, and other issues. But here, if you look at a major pathologic response, you see that they had that in 97% of patients, 67% had a pathologic complete response. And as I said, they did not seem to have increased surgical complications. And if you look across going from low risk to high risk, you see roughly the same pathologic complete response rate, no matter what the stage is. I mean, obviously, these are small numbers and there's some variability in the numbers, but there doesn't seem to be any big differences. So I think further food for thought in terms of immune therapy in this setting. I will say we tend, instead of dual checkpoint, we tend to give single agent, as the Memorial Group did. And we tend to give it for a longer period of time. I don't think we only need to go give 2 doses and then rush into surgery. We think actually you're better off giving it a little bit more time. So we tend to use the Memorial approach as opposed to the niche study. Looking at Keynote 177, so this is the first line immunotherapy study, and you can see that patients were randomized between Pembro versus a whole host of investigator choice therapy, and then there was a optional crossover. And these are the updated survival curves that were published by Luis Diaz in Lancet Oncology. Luis and I were fellows together, so it's always nice to see him publish a nice paper like this. And you can see that basically the updated results with the check marks going way out past that 3-year mark, it still show a really nice hazard ratio in favor of the pembrolizumab group, with a hazard ratio of 0.74. You see that initial difference in the curves as therapy starts, probably reflecting the kinetics of chemo response. The chemo tends to respond a little sooner, and but then the curves cross really at about the 6-month or 8-month mark, and you see the advantage and sustained advantage of immune therapy. Looking at the various subgroups, this is the forest plot, and you can see that really across all the subgroups you get benefit. One of the things that I've always been fascinated by is the fact that BRAF patients, we think of BRAF as kind of this overwhelming biomarker and causing this aggressiveness, and yet if you're BRAF MSI high, it's tamed by the immune system and kind of gets outweighed by the immune system. So that's actually something that's nice to see, but you can see there really was no difference. Yeah.
I don't know if you know, but I think it was the last couple of weeks, they had the 2 big phase 3 trials in endometrial cancer. Of course, they have a lot of MSI high there, and both trials, very similar results, but it was chemo plus IO. They didn't even have an IO, so I don't know what they're going to do. But it did bring up the issue, because we talked about it there, what do you do with a patient with MSI high who either is very, very symptomatic and really can't afford to have progression, or maybe they have liver mets and they need it to be shrinked? Would you add chemo plus IO to a patient like that?
Well, so there's a cooperative group trial looking at this of chemo plus IO in colorectal cancer, so I think we'll have the answer soon. In my own practice, if I'm waiting on molecular testing results, highly symptomatic patient, I've definitely started with chemotherapy at times and then switch over to IO when it's a little bit more controlled situation. I think that's a reasonable thing to do.
Same thing they do in lung.
Yeah.
Same exact thing before they get the EGFR back or whatever. Okay, keep going.
So Checkmate 142, this was a study it was mostly in the second line setting. There's also a cohort 3 with the dual therapy in the first line setting, but this looked at Nivo versus Nivo Ipi and kind of set that, help us figure out what do we want to use, 1 drug or 2 drugs. You're going to get some higher toxicity, obviously, as you use both. And you can see that you have that higher response rate when you combine both drugs. And so, you'll see it differ from study to study, but when you add the dual checkpoint, you're going to get an extra, 20 or so percentage points, 15, 20 percentage points on the response rate, but then you're going to have higher toxicity. It's just sort of food for thought in terms of trying to figure out whether to use 1 drug or 2. And that's a conversation with patients. And it kind of gets back to the point you said earlier, Neil, where if I really convinced I'm going to need a response in order to prevent an issue, organ failure or something else going on with the patient, I might use a dual checkpoint approach. And if I have time in terms of growth kinetics and other things, then single agent would be reasonable as well. And these are the overall survival curves, just showing that in terms of survival, both of those cohorts 2, cohorts 3, do quite well, either first or second line, the Nivo and Ipi. From a safety standpoint, again, as you look across cohort 1, which is the monotherapy, versus the other 2 cohorts, which are dual therapy, you're going to see higher treatment-related adverse events and immune-related adverse events. But for someone where you're really banking on response, it might be worth it, and it's something to talk about. The other thing, Neil, that has surprised me is now that I'm asking everyone, the percentage of people with squirrely potential autoimmune diseases in the past is higher than you think, where they say, oh yeah, I think I might have had Crohn's a long time ago, or sorry, maybe it was something else. And you're trying to dig through the records and find it. So if I'm worried about, kind of a squirrely autoimmune history, I might go with a one drug, combination rather than 2. So turning now towards BRAF, this is the Beacon study, which really set the standard of care, looking at encorafenib, binimetinib, and cetuximab. And at the end of the day, the encorafenib and cetuximab arm won out. This looked at response and overall survival. And this was presented by my good friend Scott Kopetz from MD Anderson. So looking at the fact that the doublet and the triplet had very similar efficacy with, basically lower toxicity, there really wasn't much point in having that third drug. And so if you look at the hazard ratio, it was 0.61 compared to control. Unfortunately, you don't really see a flattening of the curve. So there's so many different resistance mechanisms that can occur here. And unfortunately, patients do tend to progress over time. And Scott also presented the quality of life data, just showing that there was a better time to definitive deterioration. So that was prolonged if patients were in the targeted therapy arm. And also the patient global impression of change also improved with the targeted therapy compared to the control group, so indicating that you're not sacrificing quality of life. The Breakwater study is targeting BRAF-mutated colorectal cancer in the first-line setting, looking at that encorafenib and cetuximab. And then there's a combination arm with chemotherapy. So the initial safety lead-in was just to make sure that the combination with chemotherapy was well tolerated, which it appeared to be. And some of the initial encorafenib, cetuximab, first or second line efficacy data indicated that there does seem to be a promising response rate, especially in the first line setting. You can see the CR and PR rates are close to 70%. And then looking again at progression-free survival of the various arms, first line and second line, first line across the top, second line across the bottom. These are small numbers, but it seemed to combine pretty well with either FOLFOX or FOLFIRI. And as expected, your first line curves are going to look a little bit better than your second line curves. So Scott actually made this slide, which I think is a really nice slide, looking at BRAF mutated colorectal cancer in terms of what's coming. There's an adjuvant trial that's in the pipeline. Of course, we have Breakwater and CMARC. I'll show you a slide on CMARC in a minute. It's kind of an interesting study. Beacon, of course, is done. And there's multiple studies in the refractory setting going after this patient population. So CMARC, I thought, was kind of an interesting study, and it's looking at whether or not we should be adding the BRAF targeting approach to immunotherapy. This is in BRAF mutated MSI high patients. And what's interesting, is the targeted therapy, your encorafenib and cetuximab, may also have immune modulating effects in addition to the targeted effects. So I think it'll be very interesting to see how that trial reports out. because the MAP kinase pathway has been shown to be important in immune regulation, and we've seen multiple settings where a checkpoint inhibitor and a targeted kinase inhibitor, tyrosine kinase inhibitors, seem to combine really nicely. This is a study in SWOG. We have this open, as do multiple others, looking at encorafenib, cetuximab plus or minus nivolumab. There's a lot of data showing that these BRAF tumors seem to be inflamed. And so adding early on the nivolumab, and this is for MSS. So unlike the CMARC study, it's proficient MMR, microsatellite stable. So those two trials, I think, will be a nice sort of mirror image of each other to see how that goes. And you can see there's a 2-to-1 randomization with 75 participants, and Van Morris, also at MD Anderson, is the PI of that study. Turning now to HER2, colorectal cancer. So John Strickler from Duke presented this data looking at the Mountaineer study. And what's kind of cool about this study is it started out as an investigator-initiated study and then got converted into an industry-sponsored study, kind of fast-tracked. So that's always nice for investigators to see their initially this small single-center kind of investigator trial go up to a nice big trial to show the proof that it seems to be working pretty well. So this looked at tucatinib trastuzumab versus tucatinib alone. And you can see there the efficacy endpoint was overall response. And here you see the combination arm, tucatinib and trastuzumab, 38% response rate, which is actually pretty impressive response with a medium duration of response per blinded independent central review of 12 months. And here's a waterfall plot looking at the combination. Again, the tucatinib is your small molecule. It's blocking the signaling. Trastuzumab is your large molecule monoclonal antibody. And you can see that there's a number of CRs and PRs, and about 65% of the patients had at least some type of tumor reduction. These are the PFS and OS curves. Again, we don't quite get a flattening here, but nonetheless, good efficacy and a good option for patients in this setting with tucatinib and trastuzumab. On the other hand, tucatinib alone did not seem to work. It kind of reminds me of the MEK inhibitor and BRAF inhibitor story and BRAF. Tucatinib alone did not seem to work. And it's been shown by Scott and multiple others that there's a number of feedback mechanisms where you kind of need that monoclonal antibody at the top of the signaling, if you will, to prevent some of the feedback mechanisms from just going right around your drug. So looking at the treatment emergent adverse events greater than 10%, and I think most of these, I think we're all pretty familiar with any of the tyrosine kinase inhibitors. You got your GI, some diarrhea, nausea, some fatigue, rash, et cetera. So it seemed to overall be fairly well tolerated. You can see the incidence of grade 3 or higher was pretty low. Obviously, need to keep an eye on the hypertension. So the follow-on study is Mountaineer 03. This is a global phase 3 trial, and this is going to be in the first-line setting, looking at tucatinib, trastuzumab, and FOLFOX versus FOLFOX with one of the other targeted therapies, with the primary endpoint being progression-free survival and secondary being overall survival and response. So we're looking forward to that trial getting completed. G12C mutations, so adagrasib. This was a New England Journal paper by Ronnie Yeager looking at this G12C inhibitor with or without cetuximab. And this is a drug that irreversibly and selectively binds KRAS G12C in its inactive state, and it's highly potent and highly selective. So this is actually fairly rare. It's hard to find these patients. We've been looking and only really had a handful over the last few years. But you can see that you get a nice set of partial responses in the monotherapy arm. You look at the progression-free progression-free survival curve in the upper right, and it's not long-lasting. You see it's down to 15% at the 12-month mark. Fairly good survival with close to 70% survival at the 12-month mark. But nonetheless, we're not getting that kind of flattening that we'd like to see with immune therapy. When you combine them, your response rate goes up. Here you can see, almost more than half of patients are getting a partial response or at least stable disease, and you're going up on your 12-month progression-free survival to 24% with an overall survival 61% at 12 months. And so this is sort of your summary here, just showing that the partial response rate went from 19 to 46% when you have the cetuximab in there, and a fairly decent stable disease. You can see the number of progressors was actually 0 in the combination arm. So some at least stability, if not response, when you're able to pick these folks up and get them on these studies. And the turning now to another G12C inhibitor, this is sotorasib. This was the code break study, just looking at sotorasib and panitumumab. So basically a similar subset of patients. This was second line and beyond. And again, showing a fairly nice percentage of tumor responses. And they say here there's a reduction in target lesions in 88%. So not a lot of progressors, which is always nice to see. And then in the swim lanes to the right, you can see the sort of the kinetics of response and progression, and also that many of the patients still have ongoing treatment. These are changes in target lesions over time, and again, not quite like immune therapy where they kind of flatten, but you do see some nice flattening, and then you start to see some of these tumors escape, and you see that some of them start to progress over time. But overall, pretty good control, at least for the first 6 months on the study. Treatment-related adverse events, again, I think pretty similar to what we've seen with other agents. You get some rash, dry skin, pruritus, nausea, that type of thing. Unfortunately, fairly rare on the grade 3 side effects. You do have to keep an eye on magnesium levels with this drug class. And that's it. Thank you so much.